We are live.
A very good evening to all of you and welcome to one more webinar, Glaucoma for All, from the AIOS ARC panel. So as you all know, glaucoma is a very important topic and a lot of times there could be misconceptions or mistreatments done. So today we are having a fantastic expert panel and we would like to welcome them all. Dr. B.K. Naik sir, Dr. Shweta Tripathi, Dr. Manish Singh, Dr. Manju Pillai, Dr. Shikha Gupta, Dr. Manavdeep Singh, and Dr. Prafulla Sarma. Welcome to all of you. We are also having our moderators, Dr. Sachin Dharwadkar and Dr. Amit Porwal. So, welcome to one and all for this fantastic webinar where we are going to have a bouquet of relevant topics which are going to be discussed threadbare so as to help us in our day-to-day glaucoma practice, and also introducing the hot and sizzling saransh where gist of articles from glaucoma will be presented. So over to you, Dr. Sachin, for the further moderation. Dr. Sachin, you're on mute. Please unmute. I think he
Am I
dropped.
audible now?
Yeah.
Okay,
Dr.
so
Sachin.
very good evening, everybody. And after that brief introduction from Dr. Anaga, I welcome all the speakers and I think our first presentation of the day. And the first presentation will be done on a very important topic of history and is titled Important History Pointers in the Glaucoma Patient, What Not to Miss from Diagnosis to Therapy. It will be given by Dr. Gazela, who's working at RML Hospital in Delhi. Over to you, Dr. Gazela. You can upload your presentation.
Thank you, sir.
Everybody else mute for the time being.
Is my screen visible?
Yes, it is.
It's
It's
visible.
visible.
Okay. So I'll be talking about the important history pointers to take in a glaucoma patient today. So as we all know that most glaucoma patients do not have any symptoms at all, and they are diagnosed just without any symptoms. And few of them will, however, have symptoms like blurred vision or a constant change in glasses prescription. Some may complain of colored halos, pain, or very few may have this subjective visual field defects. But these are all very non-subjective symptoms which are overlapping with other ophthalmological disorders. In the PACG spectrum, if the patient is still in the PAC stage, they may have these symptoms of transient blurring, colored halos, or mild headache, which corresponds to the episodes of high intraocular pressure. And of course, if we don't diagnose or treat them, they will go on into PACG. And if they have acute PAC, they will have this rapid loss of vision, acute severe pain associated with vomiting and prostrations, and redness and photophobia due to the very high intraocular pressure. So the demography of glaucoma is that with age, the risk factor of developing glaucoma increases, and angle closure is more common in females, according to many studies. And some secondary glaucomas like pseudo-exfoliation is more common in males. Many times we get patients in our OPD who are already diagnosed cases of glaucoma. They may come for a second or third opinion. So in these patients, we should ask, when were they diagnosed with glaucoma? This will help us to know how long they have been on treatment, what is the chronicity of their disease. Then we have to ask about what was the baseline IOP before starting of the treatment. This will help us to give a target IOP. Also, we have to ask whether the IOP was maintained at this target IOP or what was the IOP along the treatment course. Then we have to ask what was the type of diagnosis made, because sometimes PACG may also be misdiagnosed as POAG. And we have to ask along this course of treatment, what was the AGM given to them, whether the AGM was changed along the course of the treatment, why was it changed because of the ineffectiveness in lowering IOP, or if they had developed some allergy to it. And if they have developed any allergy, what is this history of this adverse reaction to the medication? We have to ask for history of any laser procedure, like a YAG-PI, or if they give a history of a laser and we do not find any iridotomy, most likely it will be an SLT. Any intraocular surgery, especially cataract surgery, if it was complicated or not. Sometimes they may have documents of the cataract surgery where it may be written if any complication has happened, where was the IOL placed, was it placed in the sulcus, and what was the number of the IOL. Sometimes this may also help us to diagnose cases with high hypermetropia or nanophthalmos who have subsequently developed glaucoma after cataract surgery. In past medical illness, respiratory diseases like asthma and COPD, these will be contraindications to topical beta blockers. Or if a patient gives history of sleep apnea, this might point to the diagnosis of NTG. Any cardiovascular diseases like arrhythmias or heart blocks, again, will be contraindication to beta blockers. Or if they give a history of having carotid artery stenosis or atherosclerosis, it will point to NTG. Hypertension, if we overtreat, may worsen the glaucoma risk and also lead to progression. Certain vasospastic disorders like migraine or Raynaud's will also increase the incidence and severity of glaucoma, especially NTG. We have to ask if there is any history of past hemodynamic crisis, like any severe blood loss, PPH, because if the patient has a sort of optic dyspallor, it may mimic glaucoma. Diabetes, which is becoming an epidemic in this country now, is known to be associated with POAG, and also we have to rule out NVG in these cases. Thyroid disorders, there is an increased prevalence of POAG in Graves' disease, and also we cannot forget secondary glaucoma in the form of thyroid ophthalmopathy. In the CNS, if there is any carotid cavernous fistula history or any arteriovenous malformations, this may lead to elevated episcleral venous pressure, leading to secondary glaucoma. Any previous head injury, any stroke, CVA, or any pituitary lesions may have a type of cupping or visual field defect, which might be confused with glaucoma. So we have to ask this history in these patients. Any musculoskeletal diseases like osteoarthritis, rheumatoid arthritis may ultimately affect the ability of the patient to administer eye drops. And presence of any urinary stones or CKD may limit the use of carbonic anhydrase inhibitors. In drug history, we know that steroids are being used over the counter in our country, and they are also present in many traditional medicines. So we have to ask for this history. This is also important in a case of a already diagnosed, treated glaucoma patient. Sometimes they may have a controlled IOP for a long period of time and suddenly come with very high IOP. So we cannot understand what is the cause of this high IOP. We have to ask them if they've recently used any new medication and probe if it is a steroid. We ask for the use of any anticoagulants in case we need to plan surgery and if we have to stop these medications. Some interactions which can happen if you use carbonic anhydrase inhibitor oral can be with cyclosporin, digitalis, lithium, aspirin, or effect of oral antidiabetics may be decreased in these cases. There are certain drugs which can precipitate angle closure glaucoma, antihistamines, antidepressants in the form of TCAs, SSRIs, MAO inhibitors, adrenergic agonists, topiramate. So we have to ask for this history if there is any acute angle closure glaucoma. In past history, if a patient is saying that there are similar complaints in the past, this might mean that it is due to intermittent attacks of angle closure or recurrent attacks of any glaucomatocyclitic crisis. So also there might be repeated attacks of uveitis, especially viral keratouveitis. Secondary glaucoma, we have to take history to rule out any uveitis, any NVG, asking the patient if they've had any sudden decrease in vision, any laser was done in the form of PDR, if there is any history of ocular trauma, any intraocular surgery. Family history also very important in all PACG, POAG, ocular hypertension. We have to ask if there is any history of glaucoma blindness in a first or second degree relative, because this may mean that this glaucoma is very, very severe. So we have to treat this patient more aggressively. This also helps to tell the patient that they have to ask all their family members to go for a screening. In personal history, we have to ask about the driving status because some patients may have a lot of their visual field already gone, so they won't be able to drive anymore. And if they are doing any yoga exercises which involve Valsalva maneuver, holding breath, because this will increase the intraocular pressure. If they are taking any excessive water intake in the morning, if they are a smoker, alcohol intake, or if they take caffeine, if they are used to wearing tight neckties, which will lead to rise in intraocular pressure, or if they play any wind instruments. So social history is important because we need to know whether the patient can afford or comply with the treatment because it's a lifelong treatment. How regularly can they come for follow-up? And how will the disease affect the patient's work and family life? In eye drops, we have to ask, especially if the eye pressure is not getting controlled, even though you have prescribed the correct medication, we ask them, how do they instill the eye drops? Preferably, we ask them to show how they are instilling the eye drop in front of you and who is instilling the eye drop, whether they are doing it themselves or a caregiver. When are they using the medicine? Have they instilled it before coming before the examination to you? And what is the time gap they are keeping between two medications? So the take clinic message is that, as we all know, what we've learned in medicine, that 70% of the diagnosis approximately is made with history itself. So history helps in accurate diagnosis and treatment of the patient. We know that time is always a constraint in OPDs, but we should learn to master the fundamentals of history taking so that we'll be able to maintain a proper quality of care. So thank you and happy diagnosis in glaucoma.
Okay, so that was a very, very comprehensive overview of most of the pointers that are supposed to be elicited in the history. That was a very nice presentation, which was crisp and short, Dr. Ghazala. So I think we would ask our panel now whether they would like to add, in short, any other few points they think are really important or stress on the ones which people should not forget. So, Dr. Manish?
Yeah, I think very nice presentation. In fact, lot of important points she has covered, very exhaustive. One important thing is the history of steroid, which I think sometimes we do miss because sometimes patients are using certain medications for allergy, eye drops, which patients are not aware that they contain steroid. So what we do, sometimes we tell the patient to bring the eye drop which they are using, or if they are using any particular oral medication, we often tell them to bring the medication so that we also check ourselves what medicine they are using, because not every patient is aware which medicine contains steroid, which doesn't contain steroid. Steroid is something which we should be actively trying to find if there is any history. Even homeopathic medicines often contain steroid. So we do ask them whether they are taking homeopathic medications or not. We have seen a few patients where patient have received some subtenon Kenacort or a IVTA 3 months or 6 months back, but patient is not aware that what injection was given. So those cases, going through the old record will help, because patient may just inform you that some injection was given. What actually was given also need to be checked. But a beautiful presentation.
Any other quick points? Anybody? Dr. Nayak,
Yes,
sir?
yes,
Dr.
I
Pranam,
have,
sir?
I have some.
Yes, sir. Very
points.
quickly. Yes.
First point is that history is not complete unless you have examined. So take history, go to the examination, and then go back to the history in view of the findings of the examination.
Wonderful. Wonderful.
So this is one point. And the second point is, if you can rule out advanced open angle glaucoma, if you can rule out acute attack of angle closure glaucoma, if you can rule out the subacute attacks of glaucoma and angle closure glaucoma, then the first thing which you must tell the patient and insistently tell, and that is that none of the symptoms that you have, because they have many symptoms, they are not related to your disease of glaucoma. I'm talking of the patients who have symptoms and who have glaucoma. Both the things are there, and you have ruled out these certain points which I've told. Then you must put in their mind that these symptoms are not related to glaucoma. It has a lot of implications that we cannot explain in this short time.
Oh, point well taken. So now I think we would move on to the next topic of our today's discussion. and that would be covered by Dr. Susmita Paul. And her topic is my 10 points for optic disc exam and documentation. So, Dr. Susmita, are you there?
Can't see her. Oh, yes.
Dr. Susmita?
Yes, yes. Yeah, she has started.
Okay. So, I think please share your slides, please.
Great talk, Dr. Gazelle.
Good evening to all. Am I visible?
Yes, you are
And
visible and
audible?
audible. You can go ahead.
Today, hello. Hello.
Yes, you are audible. Please go ahead.
Okay.
Please go ahead. You're audible.
My topic of discussion is my 10 points of optic disc examination and documentation. Myself, Dr. Susmita Pal. Starting with the importance of careful examination of optic disc to differentiate between normal optic disc from glaucomatous optic disc, to differentiate glaucomatous optic neuropathy from non-glaucomatous optic neuropathy, to identify physiological variations and congenital anomalies of optic disc. But it is the only examination is not sufficient. The documentation of all the detailed findings are helpful for further comparison in order to detect glaucoma at its early stage and to evaluate changes over time. What are the methods of optic disc examination? Using slit lamp biomicroscope and non-contact lens gives a best stereoscopic view of optic disc. We can also use direct ophthalmoscope for examining optic disc. What are the method of documentation? Obviously, disc photographs are vastly used, but a detailed annotated schematic drawing by the examiner are always useful method of documentation. Now the 10 parameters of optic disc evaluation, that optic disc size, shape and configuration, optic cup, CDR and shape configuration, symmetry, neuroretinal rim, pallor, retinal nerve fiber layer, disc hemorrhage, any vascular changes, parapapillary chorioretinal atrophy, and the state of lamina cribrosa. How to measure the size of the optic disc by using a slit lamp biomicroscope. The slit lamp viewing piece and the light column are kept coaxial. The intensity of the beam are kept brightest. Magnification preferably set at 10x. Then reduce the height of the slit beam, coincide the slit beam to the disc margin. Then read the measurement from the graticule of the slit lamp to get the vertical diameter. Then rotate the beam and measure the horizontal diameter as well. We can also use direct ophthalmoscope to measure the disc size. Use the 5-degree aperture of the ophthalmoscope to project a circular spot close to the disc. The circle has a diameter of 1.5 millimeter, which is slightly smaller than the size of an average disc. Then compare the size of the optic disc with the circle. Determine if the disc is small, average, or large in size. To identify the disc margin, identify the scleral ring. To determine the disc margin, identify the scleral ring, which is a white band of sclera encircling the disc. Disc is vertically oval. Vertical diameter is more than the horizontal diameter. When the vertical disc diameter is less than 1.5 millimeter, it is noted as small disc. And when the diameter is more than 2.2 millimeter, it is noted as large disc. Few diseases, optic disc diseases, are commonly associated with a small disc like optic disc Duchenne, pseudopapilledema, and NAION. Whereas normal tension glaucoma, optic pit, morning glory syndrome are more commonly associated with large optic disc. Here in this slide, we can see variable size and shape of the optic disc. In the first picture, we can see that the vertical axis of the disc is rotated more than 15 degrees from the vertical meridian. It is called a torted disc, which is different from a tilted disc. The tilted disc is a three-dimensional structure where there is angulation of the anterior-posterior optic cup axis. In high myopic eyes, the disc size may be highly variable. The disc size and shape is highly variable. The disc size may be larger. It may be tilted or torted. Determination of the disc margin may be difficult due to the presence of large peripapillary atrophy, as we can see in the fifth picture. And gross tessellation makes it difficult to evaluate the RNFL changes. But the myopic discs are always to be examined very carefully, because myopic discs are frequently glaucoma suspect, and myopic eyes have an increased risk of developing primary open-angle glaucoma. Cup to disc ratio. To determine the cup margin, we should look for the optic nerve blood vessel, and follow the optic nerve blood vessel and note the kink in the vessel to determine the cup margin. The optic cup is horizontally oval. The contour of the cup is more important than the color of the optic cup. And the CD ratio varies with the size of the optic disc. As we can see in the first picture, the small disc, small CDR, the medium-sized disc, and the large disc, large CDR. We should always carefully look for any asymmetry between the two eyes. Any CDR asymmetry of more than 0.2 in the absence of significant inter-eye difference in the size of the optic disc raise a suspicion for glaucoma. In the first picture, you can see that the left disc is larger than the right optic disc. That gives rise to a CDR asymmetry. But in second picture, the CDR asymmetry is due to the size difference in the size of the optic disc as well as the glaucomatous cupping in the right eye. The neuroretinal rim is the most important parameter of optic disc evaluation. Optic disc is vertically oval and the cup is horizontally oval. It gives rise a characteristic configuration to the neuroretinal rim. The inferior rim is thicker and widest. The inferior rim is widest, followed by the superior and then nasal and temporal. It is the ISNT rule. Any deviation from the ISNT rule gives suspicion to glaucoma. The cardinal feature of glaucoma is loss of NRR from its inner edge. The loss may be focal or generalized. Focal loss may be notching or narrowing. Notch is a focal loss of NRR from its inner edge, where the rim to disc ratio is smaller than the adjacent area. And sometimes for describing a NRR, we use the term thinning, but thinning is not the correct term, because thinning is the loss of depth, whereas the narrowing is the loss of width. For clinical examination purpose, it is better to use the term narrowing to describe a NRR. The inferotemporal and superotemporal NRR usually get affected first. In advanced glaucoma, the rim remnant are located mainly in the nasal sector. The pallor cup discrepancy, it is an important parameter to differentiate between glaucomatous and non-glaucomatous optic neuropathy. As we can see in the first picture, the disc, the area of cup is more than the area of pallor, which is the characteristic of glaucomatous optic neuropathy. Whereas in the second picture, the cup is less than the pallor. That is the characteristic of the non-glaucomatous optic neuropathy. But it is not always the pathognomonic. The rim pallor that is out of proportion to the degree of cupping may sometimes occur following previous episodes of very high IOP, such as following an episode of acute angle closure attack. The retinal nerve fiber layer is most visible in the temporal, superotemporal, inferotemporal, and superotemporal sector. They are visible as bright striations. Retinal nerve fiber defect may sometimes be missed while examining in undilated pupil. So it is always best to dilate the pupil where not contraindicated and use the red-free illumination to examine the retinal nerve fiber layer. Retinal nerve fiber layer may be localized or generalized. As we can see that in the first picture, wedge-shaped defect, running towards the optic disc margin and touching the disc margin, occupying not less than 60 degree of the circumference of the disc. It is not pathognomonic. It is the early sign of glaucoma, but the slit defect is
Dr.
not always.
Susmita, we have just half a minute to go. So we have to wind up in half a minute. Thank you.
Okay. Okay, sir. But the slit defect is not always specific. About 10% of the normal individual might have a slit defect. A slit RNFL defect not reaching the disc margin and narrower than 1 arterial width is considered non-pathological. A disc hemorrhage is a splinter or flame-shaped hemorrhage oriented radially and perpendicularly to the disc margin, located within 1 disc diameter of the optic disc. Most common location is inferotemporal and superotemporal. We should always rule out an optic disc edema, papillitis, diabetic retinopathy, and retinal vein occlusion. The disc hemorrhage are transient. Average duration is 6 to 12 weeks, and they may recur at the same or different location. They are more common in normal tension glaucoma.
Susmita, I think we'll have to conclude.
Yes, sir.
Yeah, because our time schedules are very tight. So I think
Yes, sir.
it was a very nice presentation thus far. I just
Yes,
want to invite some comments from Dr. Shikha. Shikha, are you there? Hello, Shikha. Okay, I think Shweta is here. Yeah, Shweta, any comments on any
that
nuggets
was,
you would like to offer to the students?
definitely.
Yeah.
So it was a very nice presentation, and just 2 points I would like to just focus here. One is that whenever we are talking about cupping, we have to keep in mind about the physiological cupping, because you have to look for the NRR color. So that pinkish color has to be there. And second, when you were talking about the disc hemorrhage, you have to see, because this is a very important point, when you see the progression of your disease. So any occurrence of the disease, disc hemorrhage, it is important that your disease might be progressing. For that, you need to do a fields and then repeat the fields after a certain period of month, probably 2 or 3 months, and see that whether your disease is progressing or not. And then you can do the necessary intervention. Rest, everything is fine. Thank you, Dr.
Okay,
Devakar,
wonderful.
for making me a part of this. Yeah.
So now I think we will invite a quick fire comment from either Manju or Shika. Anything new about disc documentation? Anybody wants to share from the panel? They can also join in for the next a minute or so we have on this discussion.
Sachin, can you just
anything new about disc
the
documentation from routine
stop
photography?
share screening?
Can you stop the screen sharing? Susmita,
Yes.
can you stop
Yes,
the
sir.
screen share, please?
Yes, sir. Yes, sir.
Yeah, okay. So one important thing is that we need to document always the disc, either by photography or by drawing. That's very important, because that can give us an idea after 3 or 4 years whether there was any change. And that is very important. When you work in an institute, it may not be the same person who is going to see the patient later on. So it's very important to document. And second thing is, as Shweta said, in the disc hemorrhage, if you see the disc hemorrhage, you should either step up the treatment or switch the drugs so that the progression can be retarded.
Okay. So wonderful. So very nice comments from our expert panel. All the students and the ophthalmologists attending alike should remember these two very important points. Also, documentation is a must. Now it's not a luxury. It's a absolute necessity if you're managing glaucoma patients. Okay, so with that, I think we'll go to the next topic for the day, and
Sachin, just one thing.
Spoken by
Sachin, just
yes,
one thing.
Yes, sir. Nayak sir wants to intervene.
Yeah, because she pointed out about, you also said about the photography. I think photography is very simple, but people think it is because not high tech. That's why we tend to ignore. But definitely compared to the whatever drawing that you make, that you will understand better yourself. But photography, if it is taken a very good photograph, anyone even 10 years down the line, someone else will see that what is the condition today and what was 10 years back. So that is important. We should not ignore.
Point, sir. Very, very important point. And also we can miss, as you rightly said, we can also miss small things if we don't do a photograph.
Yes,
like very, very small slit NFL defects or very, very small hemorrhages we can miss. which are along the blood vessel. So yes, sir, very relevant point. Thank you so much. So with that, we go to the next talk by Dr. Surojit Sen, and that his topic is gonioscopy, how and when, and the role of AS-OCT. Okay, we shall request all the speakers to stick to their time. Thank you so much. Surojit, are you there? Yeah, he started sharing the screen. Wonderful. Screen is seen. Can you just maximize it? Surojit, you're muted. You are not heard. Surojit, you're muted.
Yes. Am I audible now?
Yes, yes. Loud and clear. Your slides are seen. Please go ahead.
Okay, thank you. Thank you. Good evening, everyone. And I'll just talk on gonioscopy and how and when to do it and role of AS-OCT in glaucoma. I don't have any financial interest. So what is gonioscopy? As we all know, it is the evaluation of angle of the eye, but not only the angle of the eye, it gives us a lot of information about the peripheral iris also and also the peripheral endothelium. The basic principle is overcoming the total internal reflection so that the light coming out from the angle structure, which needs the gonio mirror to overcome the critical angle of tear-air interface so that the light can come out and we will be able to see the angle. It can be grossly divided in direct and indirect methods. The direct can be further divided in diagnostic like Coppes lens and surgical lenses like Birkin lenses, Swan-Jacob lenses. The indirect can be divided in diagnostic and therapeutic. The diagnostic most commonly used is the Goldman mirror, Zeiss mirror, Posner mirror, Suzman mirrors, and therapeutic lenses, Rich lenses and Latin lenses, which we use for the SLT. And the two ways to do the gonioscopy, it is a direct gonioscopy where the light is coming out directly from the angle. It is not getting reflected from anywhere. And it's a separate light source and handheld slit lamp to examine it. Another option is to use a operating microscope to examine the whole angle. It is usually used for the pediatric cases or examining under the anesthesia, but if it is done under, since it is done under supine position, sometimes artifactually opening of an angle might occur. And most commonly performed is the indirect gonioscope where the light is coming from the angle is getting reflected from a mirror and we are examining it. The patient is in sitting position in the slit lamp and various methods are there to do it. So I'll just briefly discuss the basic steps to follow while doing the indirect gonioscopy. The procedure is explained to the patient first and the eye needs to be properly anesthetized with topical anesthetic eye drops. The room light should be dim. The patient should be comfortably seated on slit lamp. Gonioscope is gently inserted in the eye and the patient is asked to look straight ahead, that is in primary gaze. A small 1 mm by 1 mm slit beam is used to examine all quadrants in high magnification without putting any pressure on the cornea and avoiding any light through the pupil. Once all quadrants are examined and the angle appears narrow, then the beam is increased and the cornea is pressed with the gonio to see if the angle is opening or not. This is for the indentation gonioscopy. Little bit more about the indentation gonioscopy. It is usually done with a flatter curvature gonio mirror and the diameter should be lesser than the cornea. It is this one is the Posner and Suzman lens where the diameter is around 9 mm. We place it over the cornea and we gently press the cornea to differentiate between the synechial and appositional angle closure. If it is the appositional angle closure, then it will open up, and if it is the synechial angle closure, it will not open. Another way to see it is with manipulative gonioscopy. It is done with the Goldman mirror and where the cup size is larger and also the viscomaterial is used as a coupling agent. Here, in this case, if we press on the cornea, artifactually it might close down the angle also. So in that case, we ask the patient to look towards the mirror. And to get the over the hill view, which is actually an open angle, which might look like a closed angle. So when to do the gonioscopy? It should be done to diagnose and treatment in all kinds of glaucoma, primarily to differentiate between open angle and closed angle glaucoma. But apart from this, in all cases of statistically raised intraocular pressure, glaucoma suspects, shallow anterior chambers in aneurysm grade 1 or 2, pigment dispersion syndrome, pseudoexfoliation, trauma, uveitis, neovascularization of iris, gonioscopy should always be done. We should also know when not to do gonioscopy in cases of hyphema, suspected globe rupture, any ocular surface infection, and corneal epithelial defect. We should avoid doing gonioscopy. The common errors made during the gonioscopy are the mistaking the iris processes at peripheral anterior synechia, diagnosing angle recession without comparing the other eye, misinterpreting the pigment of Sampalisi line as the pigmented trabecular meshwork in an angle that is actually closed, by inadvertently compression leveling a closed angle as open, leveling an open angle as closed in case of lightly pigmented trabecular meshwork, and mistaking blood in Schlemm's canal as neovascularization of angle. Once the gonioscopy is done, it is very important to document the findings. The Schreis classification is based on the angle depth system, and it is graded from 1 to grade 4. And most commonly used is the Schaffer system, where it is based on the angular width of angle recess. It is the grade 4 is the open angle. This is just the reverse of the Schreis grading, and slit angle is the narrowest angle grading. At Shankar Netralaya, we document all the findings with in this way. First, without any indentation, we document see all the quadrants, and most posterior structure seen is documented. Trabecular meshwork pigmentation is graded from +1 to +4. Convexity of the iris is noted. Any peripheral anterior synechia and its extent is noted, and any other or abnormality in any quadrant is noted. Then the indentation gonioscopy is done, and all the findings are noted in similar way. Showing you a few examples of gonioscopy. This is the normal open angle. All structures are nicely visible, and this is the effect of indentation. No structures are visible in this picture, and here you can see all angle structures are visible after the indentation. This is a photo of the regular pattern of iris processes, and this is the irregular pattern of showing the peripheral anterior synechia. Densely pigmented angle structures are seen in the pigment dispersion syndrome, where the angle structures are not very much identified, and the other sign in slit lamp is the Krukenberg spindle may be visible. Angle recession, wide ciliary body band here, the iridodialysis and cyclodialysis, neovascularization of angle. This is the patency of trabeculum. The trabeculectomy stoma can also be checked with gonio. This is the silicon oil bubbles at the angle. This is the anterior, the large, long, those iris processes in axial field rigor syndrome, which crosses the Swalvis line. The foreign body at the angle, and this is the iris cyst. Coming to the important part of surgical gonioscopy, since the minimally invasive glaucoma surgeries are nowadays pretty common, so doing it in the operating system, in little bit modification is required. You need to tilt the head of the patient away from the surgeon, and also the microscope around 45-degree from the surgeon. With that, the special surgical lens is used to see the angle, and this kind of view is there, and the surgery is performed in the angle. So the conclusion of the gonioscopy part is that no glaucoma management should be done without gonioscopy, and a routine gonioscopy is essential to master the art and differentiate normal from the abnormal. Greater emphasis on making gonioscopy part of comprehensive ophthalmic evaluation should always be done. Coming to by the second part of my presentation, that is the anterior segment optical coherence tomography. AS-OCT is a cross-sectional high-resolution imaging modality that uses low coherence interferometry to achieve axial resolution in the range of 3 to 20 micron. It involves the measuring the interference between the reference and the reflected beam of the infrared light. It limits the penetration depth to the anterior segment. Multiple S scans are reconstructed to form a B scan-like image. These are the various types of AS-OCT. It can be time domain, spectral domain, and swept source AS-OCT with different advantages of those machines. The protocol can be the single scan protocol, quadrant scan protocol. There is separate anterior scan protocol also, and the 3D scan. It is a swept source OCT scan of Cassia machine, and it can give you a 360-degree reconstructed image of the whole angle of the eye. The advantage of AS-OCT is it's a non-contact procedure. Patient is in sitting position. The high resolution imaging is possible. This is the rapid image acquisition is there, and simultaneous view of both angles is possible. Light and dark phase can be adjusted. The disadvantage is unable to visualize the ciliary body or posterior lens surface, and the problem of scleral definition in some eyes is a problematic thing with this instrument. This is a normal time domain photograph of a AS-OCT anterior segment. It is usually used in glaucoma to screening the closed angle and secondary glaucoma and evolution of blebs. These are the various parameters like angle opening distance, the trabecular iris surface area, and angle recess area. There are various parameters there which can be measured, but usually for the research purposes, not used for the clinical purpose that way. There is a very good aspect of using this AS-OCT in the bleb evaluation. We can see that there are various ways to see the bleb, whether it is functional or not.
Surajit, half a minute left to go.
Okay, thank you.
You'll have to wind up in half a minute. Thank you.
And the bleb, there are some blebs are there, like you can see here, the some diffuse bleb is there. This one is it's a flat bleb, and this one is showing some cystic bleb, and it's an encysted bleb. And it's a very shallow anterior chamber showing a malignant glaucoma. It is a iris cyst. We can evaluate the glaucoma valve implant also. It has various advantages over UBM, like coupling medium is not required. It is a less time consuming, risk of infection, corneal abrasion is absent, and inadvertent pressure on eye cup while scanning can influence the angle configuration. In UBM, since patient in supine position, the lens iris diaphragm falls back, the artifact actually can open up the angle. So
Rajit, I think we'll have to stop. Crossed our time.
Okay.
Just so can you just conclude with a few important points from your last slides? Just in short, 2-3 points from your last slides.
This is the one last paper what was published in the American Academy of Ophthalmology. It was comparing the gonioscopy with other anterior segment imaging tools like OCT, scanning anterior chamber depth analyzer, and UBM, and they have found that it is not alternative to gonioscopy. Gonioscopy is still the gold standard to evaluate the angle. It can be considered as in media opacity and other uncooperative patient, the AS-OCT, and can be used for objective documentation. And there
Wonderful.
You need to see AS-OCT tends to diagnose angle closure more than gonioscopy.
Wonderful. You. So point well taken, Surajit. Very nice and comprehensive presentation covering both the topics. So I think I would like Dr. Shikha to come here for this a few points on AS-OCT vis-a-vis gonioscopy. Shikha, is Shikha here with us? No. Yeah, Manish. Anything you would like to add about the AS-OCTs nowadays? Gonioscopy is indispensable. That is the bottom line. Gonioscopy is indispensable.
Yeah, no doubt, no doubt. Gonioscopy is indispensable, and AS-OCT has an important role in documentation of the angle, where you can show the patient that where the angle is closed and post laser how the angle is opening up. But when you actually want to take a decision that which patient needs iotomy or not, then definitely gonioscopy is the gold standard, especially because whether there is patchy pigmentation or early synechia formation, these things you can't appreciate on AS-OCT. So AS-OCT is a good tool for screening to show your patients, but when you actually want to do PI, you have to decide based on.
So the qualitative view of the angle definitely is not seen, like angle pigmentation, presence of synechia and all are not very well seen, except obviously the cassia, the one which gives you a 360-degree view, but again, it cannot replace your gonioscopic view. That's something that everybody should know.
Sachin, a few seconds.
Anything regarding the recent, anybody has an update against the recent AS-OCTs about
Sachin,
the
a few
detection
seconds.
of...
Sachin, I need a few seconds only.
Yes.
See, OCT is extremely important for research and thesis writing and all that. That is the purpose for which we use. We don't use it otherwise routinely in clinical sense.
Okay. Point well taken.
One thing about OCT is where we can use it practically is the lens vault and the relative lens vault now, which is a recent term where if the lens is being the main culprit of the angle closure or not, and whether remove the lens would be helpful or not. So.
Yes, wonderful. So I think with that, we have finished the time for this particular presentation. And now we'll go on to the next topic of our presentation today is by Dr. Aniket. And his topic is pulse or visual field testing and disc OCT, improving outcomes. So this is not about reading a map, but because how you would use these tests most effectively. Over to you, Aniket. Can you share your PPT?
Yes, sir. Good evening, all.
Yes. Yeah, slides are seen.
So Today we will be discussing about the improving outcomes in visual field testing and disc OCTs. So, what are the prerequisites for the visual field testing? That is, always inform the patient about the procedure before starting, because many patients are they don't know about what to do with this mouse and what we are going to do in that big bowl. So always inform the patient about the procedure before starting and give an option to pause the test in between. Many times first, if patient is doing the first time, so test may go about 10 minutes, 12 minutes also. So give an option to pause the test in between to the patient, so it can relax and it can give the routine regular test, and it can give the results better to us. And doctor or whoever technician is doing the test, he or she should do the self-testing also. And if you are comparing the patients out to the previous fields, then same strategy every visit you should follow if you want to see the what is going to happen with the patient's visual field. What is the progression in the visual field? You have to follow the same strategy. Then if you are seeing any abnormality or unreliability, then don't hesitate to ask for the repeat test. And if you are seeing the two tests done on a different machine, so better not to be compared. So we will move forward. And the most important part is the patient information and the details. So patient's name and age, ID, refraction, it should be entered in a machine previously. And pupil size is also very much important. Correct birth date is also very much important, because it is matched with the age matched data in the machine. So, and refractive corrections are also important. How much is the visual acuity? So you can see in the this column. Then if patient is having very high refractive error, try to use the contact lenses to avoid the rim artifacts. Generally, we are using the stimulus 3, but if patient having the denser cataract, having not having that much visual acuity, then you can ask for the stimulus 5 in the visual field also. Then this is the normal field, so you can see what are the points you have to see in the visual field test. So there is a reliability data threshold map, there is a grayscale map for a patient education, there is a total deviation map, numerical pattern, then total deviation probability map, pattern deviation probability map, and visual field indices are the most important for the to see the progression and what is the test is telling to us. Then there is a downwards is a gaze tracker also, so you can see whether the patient has done test correctly or patient has blinking or any movement of the eye. Then this is typically seen in the patients having the high false negative. If you see the false negative errors, these are the 53%. So these are the high false negatives. Typically, you are seeing the clover leaf pattern. It means that patient is not understanding the test. They are very much hungry or very much sleepy during the test. There will be an early dementia, or simply it is he or she is not like to taking the test. So in second example, you are seeing very much white scotomas are there. And if you see, there are many false positive errors are showing in the reliability indices. And if you see the global indices, there is an abnormally high sensitivity, and there is a mean deviation in a plus. Generally, in a normal patients, plus 2 decibels, we can say, okay, it is normal, but very much high scotomas and showing the pattern deviation very bad than the total deviation, it means it is a very much high false positives. So these type of patients are trigger happy patients, abnormally high threshold sensitivity values, that is a white scotomas, reverse cataract pattern we can say, and the glaucoma hemifield test showing the abnormally high sensitivity. Then these are the learning curves. Means if you see The first test is done on a July 7th. Then same we have repeated on a July 7th also, but it is having excessive false positive. Maybe the patient is thinking that, okay, I have not done this test very good. So whatever means he is thinking that he is putting the means he is just pressing the button. Then if you are thinking, okay, this test is not coming reliable on these days, then just ask the patient to repeat the test after some times. Then it is a test is done on 25th August. Then it is come sometimes means it is something, it is a normal fields. Then there is a learning curve. So we should think about the learning curve of the patient also. So 1 or 2 or 3 means visual fields should be there to diagnose glaucoma, or to diagnose, okay, there is a definitive scotoma. Then many patients are coming with these type of fields, and in the COVID time, because many patients means all we are using the mask for this one, and having this mask effect in a COVID means in 2020, that if patient has not taped her mask on a nasal bridge, or having a broad prominent nasal bridge, this effect can be there. So you should not diagnose it as a inferior arcuate scotoma. Then if you can see these type of scotomas, okay, blind spot is somewhat in a lower side. Okay, you should think that, okay, means first you have done a threshold test for a that diamond shaped diamond shaped. Then patient, you have to inform the patient to look at the center of the bowel where the light is. But patient has not moved his eyes. The patient has fixated over the diamond shape, and you have done the visual field. Then that visual field will be like this. Blind spot will be somewhat lower than the horizontal. So you should keep in mind that what problem will be. This is looks like a advanced scotoma, but when you means you see the patient in a refractive way, there will be a high plus lenses artifacts will be there. That blind spot is moved towards the center, and these rim artifacts can be there in high plus lenses. Then these type of high minus lenses artifacts will be there. The blind spot is moved too much periphery. And if you see these type of, okay, it is looking like a superior arcuate scotoma, but it is not started over the nasal strap, then it can be due to involutional ptosis, dermatocalasis, severe dermatocalasis can be there. So you have to see the history, you have to see the patient, and then you have to conclude, okay, you have to see clinically also, because if you are seeing superior arcuate scotoma, there can be a this one inferior thinning can be there. So some visual fields are saying, okay, enlarged blind spot can be there. Okay, it can be seen in a papilla edema cases, or optic disc drusen also. So you have to think that in that way, and you have to see clinically also. Then these type of fields can be there. Okay, all is fine. It is looking like a scotoma in superior. Means looks like a superior arcuate scotoma. In reliability indices are good, but if you see clinically, these patient having the means BRVO patient. So in these retinal diseases also, you have to think that, okay, this can be any retinal problem also in that cases. This is typically means peripheral scotomas are there in a typical retinitis pigmentosa patient. You have to see the fundus to diagnose it.
Aniket,
yes,
you have just 1 minute to go. I think few points regarding OCT also you will need to cover, right?
Yes,
so
okay, I will
arrange accordingly. Thank you.
Yes, sir. So gaze tracker in eye tracking system, you have to see whether patient have moved his eyes, or patient have how much blinking is there. So prerequisites are there, same as the take-home messages is also same, but you should correlate clinically. It is the most important. Then we will move on to the OCT. OCT, what are points you have to see in that? It is 9 points you have to see. Just I will cover the examples. What you should not miss. Okay, Humphrey visual fields coming as a normal, but you means there is a suspicious of the disc, then you have to go for the OCT. OCT is showing the inferior thinning is there. If you are advising ganglion cell complex, it is also showing the thinning. And if you are going with a serious this one, spectral is also showing inferotemporal thinning. So
Aniket, I
yes.
think you'll have to show the last concluding slide for the OCT, please, because we are running out of time. So just show your conclusions and the take-home message for the OCT.
So means in my conclusion, lower quality scans, there will be a thinner RNFL that will be showing in a red. High myopia, thinner RNFL will be there. It is in a red. Modulated nerve fibers, you have to think of it. It will show the thicker RNFL. So go for a visual field testing. Any grease ring in a means over the disc, there can be a red or green artifact can be there. You have to think of the vitreoretinal tractions also, because traction can happen and it can show the thicker RNFL also. So it can be a green artifact. And in uvitic cases, there will be a possibly RNFL edema, which can means misdiagnosed as a normal RNFL thickness. So reliability indices are most important, and don't forget to correlate clinically. Read the entire printout. Disc size is very much important. Artifacts should be kept in mind. Aging should be considered, and look for the focal change and not the overall changes. Okay, thank you.
Okay, thank you, Aniket, for that wonderful presentation. I would like Nayak sir to comment on this. Sir, I think Amit is also joined. Welcome, Amit. Sir, please,
Yes.
any most important points you would like to give for people who are using OCT and perimetry? Nayak sir.
No, means some of
How
the
to use
points.
judiciously.
Yes, some of the points that he already Aniket covered it. But the important thing one should remember that every time when you are comparing, it has to be on the same machine. Especially for OCT, this is more important, because then you can exactly take the picture exactly the same way what it was done earlier. For the different machines, even if it is same machine, same make, still it may make some difference, and even few microns difference in measurement. The change will really give you some false impression about the condition of the patient. So that is important. I think that you should remember, and it should be always good scan, because if it is a bad scan, it should not be taken into consideration at all.
Okay, sir. What about Amit? Anything you want to add to this? Pearls of wisdom about how to utilize the OCT and perimetry best. You are muted, Amit. Amit, you are muted. No, you are not audible. Anybody can come in on this. Talveer, Prasanna, anybody. Anybody wants to suggest?
Yes, so
Yeah, Shweta.
as far as the fields are concerned, I think we can go like when the patient has come to you and you feel that your disc and the fields are not correlating. So, and your disc has kind of normal and field is showing some changes. So then you need to do your field test repeated again before labeling the patient as glaucoma. Because once labeled as glaucoma is always glaucoma. So always just reassure that your disc and fields are correlating. And as very correctly said by Aniket, that you don't have to get biased by the red and green diseases. Never say that always all the red diseases are glaucoma or all green diseases are not glaucoma. So for that, we need to correlate the cases clinically as well.
Okay, so point well taken about clinical correlation. Don't believe the machines blindly. Okay, so now with that, we come to the next topic of our discussion. It is going to be spoken about by Prasanna Venkatraman from Arvind, and his topic is angle closure disease, the spectrum of disease and its management, slips and blips. Over to you, Prasanna.
Good evening, everyone. Thank you for the opportunity. Thank you, Eras and Manju Madam, for the opportunity. So I'll be talking on angle closure disease, slips and blips. So this will be the outline, basics of angle closure. We'll be discussing primary and secondary disease spectrum and few clinical scenarios. So why should we bother about angle closure? We all know the incidence of POAG is more than PACG. PACG contributes to up to 25% of all the glaucoma worldwide. But the blindness from PACG is up to 50%. The risk of blindness is 3 times more with PACG. So it is important that we understand and identify PACG. So, but if it is so difficult, why is it so difficult to pick up angle closure? It is because of the change in the iris configuration with light. You can see the pupil constricting and the angle opening. So all these changes happen in light and dark conditions. So this is why we miss angle closure. It is imperative to do gonioscopy in all AS-OCT UVM in dim lit conditions. So what we know about angle closure glaucoma, so we all know shallow AC predisposes to this, but we also have other parameters like the peripheral iris thickness, iris volume, genetics, patient's age, lens vault, uveal expansion. There are so many other factors that we don't really understand that ultimately culminates in primary angle closure glaucoma. So this is the classification from AAO. We all know this. So the typical occludability definition is 180 degrees of ITC. So I'm not going to this classification. So why is it important to identify PACS? Because they can progress to PAC and PACG. So this is the famous paper from Dr. Ravi Thomas. So it shows the progression rate of PACS to PAC and PACG. But most PACS won't require further treatment except for a PI. But PAC, APAC, and PACG will require further treatment to lower IOP. So, but if you are doing PA, why is PA not curative in all? So these are 4 different type of angle closures. So this is the pupillary block, and this is the plateau. This is peripheral iris, where the peripheral iris is really thick, and this is one angle closure where the lens vault is high. So PA will be curative in this pupillary block angle closure, but not in others. So we have to do PA in all this, but so we have to understand that mixed mechanism of angle closure does exist, and that is more common than primary pupillary blocks. So these are the different levels of angle closure proposed by Rich. So we have the level 1 at the level of iris and pupil. So that is the classic pupillary block. So the level 2 is at the ciliary body. So that is the plateau iris. So the level 3 at lens, the classic example is phacomorphic. And level 4 is retrolental. The classic example is malignant glaucoma. So this is the WJ consensus for prophylactic PA. So we have to do PA in the fellow of APAC patients, those who require frequent dilation, those who don't have medical access and can't come for regular follow-ups, and whenever a PACS is symptomatic. So this is about primary angle closures. We'll now move on to the secondary angle closures. So this is the classification that is easy to understand with. So we have secondary angle closures with pupillary block and without pupillary block. So with pupillary block can be because of seclusive pupillae, phacomorphic, aphakic or pseudophakic angle closures, silicone oil induced. Without pupillary block, we have the classic anterior pulling and the posterior pushing mechanisms. So coming to the pupillary block, so this is what we often see. So post-cataract surgery uveitis, you have the typical iris Bombay, which is relieved by PI. So PI does magic here. You can see the angle closure even in UBM. Immediately the AC depends. So this looks like malignant glaucoma, but this is not. So you can see the lens reflex posterior. So this is the UBM picture showing the same. So what you can see here is the FM. So FM is causing the pupillary block. So this happened after an uneven full SICS. So when we went ahead and did PI, the AC deepened a little bit, but we have to watch these patients with intense steroids. So pupillary block can happen by a variety of mechanisms, by vitreous, blood clot. So this is one such example by FM. So sometimes LPI will not be curative, as in this case of occlusio and seclusio pupillae and in chronic uveitis. So coming to the next thing of lens-induced angle closure glaucoma. So this is the classic phacomorphic that we see. You can see the fluid-filled clefts in the AS-OCT. So in biometry, it is always good to look at the lens thickness. You can see how thick the lens is and how shallow the anterior chamber depth is. So if you are planning cataract surgery in these patients, it is imperative that we take all precautions to avoid Argentinian flag signs. So whenever we have a high myope with shallow AC, it is imperative that we think about microspherophakia. So this is one patient who had secondary angle closure because of spherophakia. You can see the angle closure in AS-OCT as well as UBM. So UBM can also pick up the small lens. You can also see the stretched elongated zonules in these patients. Another example for lens-induced is nanophthalmos. So this is one patient of nanof where we had done phaco, and still you can see the persistent angle closure in AS-OCT as well as UBM. So this is an eventful surgery. You can see the AC depth is still shallow even after phaco. So this is the biometry. Always again look at the AC depth and again look at the axial length. So it is 16.9. And in B-scan, we can also look at the RCS thickness. So based on all these things, you can plan to do a prophylactic sclerostomy or proceed with the mannitol. Coming to the next classification, pseudophakic glaucoma. So this will be dealt in the next talk, I guess, but still. So this is the classic transillumination defect that you see because of a single piece foldable IOL in sulcus. So this patient had recurrent hyphema after phaco. We were not able to assess the IOL position exactly because of poor pupillary dilation. But when we did UBM, we found one haptic in sulcus. So it is imperative that we never put a single piece foldable IOL in sulcus because this will cause UGH. So the next classification of SO-induced pupillary block. So this patient had a SO bubble that was causing a pupillary block. So you can see the shallow AC and a deep posterior chamber. So that is also noticed in this AS-OCT. So that is why in affix undergoing SOI, it is imperative that we do inferior iridectomy. This is called Ando's iridectomy. So this patient, we did PI, we did 2 PI, and you can see the AC deepening and retraction of the SO bubble back into the posterior chamber. So coming to the pulling mechanisms of iris, pulling mechanisms of angle closure without pupillary block, we have the classic ICE syndromes. So these cause high pass and these are refractory to treatment and will eventually require tubes. So coming to the next common angle closure, NVG. So you can see the classic ectrope and UVA. These cause refractory angle closure and will eventually require surgical control of IOP. So this is another mechanism of pushing mechanism of angle closure. So this patient presented like this on POD1 after iris claw implantation. So his IOP was 34 with corneal edema and flat AC and a patent surgical PA. So this is classic malignant glaucoma. So 3 days after atropine, you can see the IOP dropped, cornea cleared, AC became deep. So the trigger here is probably intraop hypotony because of eventful cataract surgery led to iris claw implantation. So in malignant glaucoma, it is important that we understand the entire lens iris diaphragm shift. It is not only the shallow AC. So don't go with axial shallowing or central shallowing. It is the lens iris diaphragm that matters. If you have access to AS-OCT or UBM, it can easily pick up. So you can see the entire thing that is shifted. Don't just look at the anterior chamber depth. So I'll close with one case. So this 53-year-old male presented elsewhere with the complaints of floaters in both eyes since 1 month. Her best corrected visual acuity was 6.9. It was correlating with PACC. So she had PACS. So the classic advice is serial gonioscopy and review after 6 months. She presented to us 1 year later with similar complaints. We did PI, but when we dilated, we saw a lot of vitreous membranes. So this was actually a masquerade syndrome. So she was posted for diagnostic PPV. So PA or no PA decision has to be based taking the entire patient into account, or not just the angle and the studies. So to conclude, angle closure is a puzzle that has to be solved meticulously using all the available investigative modalities, not just gonioscopy. Often combined mechanisms of angle closure are involved. So treatment can vary from a simple LPA as in pupillary blocks to complex GDTs. Thank you.
Okay, Prasanna, wonderful presentation, lots of photographs, really good indeed. So that a very important point of anterior segment anatomy and the iris, the thickness of the iris, volume of the lens, all these important parameters are to be considered and to treat the angle closure holistically. Yeah, Amit is.
Am I audible, Sachin?
Yeah, you're audible but not clear. Can you go near the mic, please?
Is it better now?
Yeah, absolutely.
Okay. So, Prasanna, very nice presentation, very good photographs and all. But one thing I wanted to ask you, you showed one slide in which there was pupillary block, and you told there was a fibrinous membrane at the pupillary area, and you did a PI.
Yes, sir.
When the AC was totally shallow and the reason was FM, and there was a gap between the iris FM and the IOL, I would have gone for an anterior YAG membranectomy. One shot of YAG on the fibrinous membrane and the aqueous would have escaped anteriorly and the AC would have reformed. So I wouldn't go for a PI in such case when there is a fibrinous membrane which is causing the pupillary block. Just give one shot and the fibrinous membrane will break and then the AC will be reformed.
Correct.
I did both, sir.
Okay, that's a PI was not needed. That's what I was saying.
Okay. Okay.
Okay, anybody wants to come in on angle closure? Anybody from the panel experts as well as speakers?
One more thing, Sachin. After the TAP trial and the EARTH trial, we have to be very cautious on doing prophylactic PI in all PACS. Earlier, we used to advocate, we had some fixed indication for which we used to do a prophylactic YAG PI in PACS. But now with this trial, which is already out, I think we should be very cautious in doing a YAG PI in the PACS.
Okay, good. So, any other points, Dr. Manavdeep sir? Trupti, Manju?
I think it's very well covered. Very well covered. It was a wonderful talk, in fact.
Okay.
Thank you,
Fine.
sir.
Okay, so then I think if nothing is to be added, we'll proceed to the next talk. That will be my 5 points for the management of neovascular and pseudophakic glaucoma by Dr. Trupti Patil. She is a senior consultant glaucoma at Shankar Nethralaya, Chennai. Over to you, Trupti.
Is my slides visible?
Yeah, visible and you are audible.
Okay. Good evening, everyone, and I want to thank AIOS for giving me this opportunity. Today, I'm going to talk about uveitis glaucoma hyphema syndrome. As we know, it is a rare complication which can happen post-cataract surgery, especially when the lens is malpositioned or subluxated, which leads into contact between the uveal tissue and the lens. So usually it happens, it can occur early post-operative period or it can come after many years after the surgery. So this mechanical injury causes breakdown of blood aqueous barrier, which can result into release of inflammatory cells, RBCs, which can cause hyphema, pressure spike, and chronic inflammation. Sometimes these patients can be associated with cystoid macular edema. So usually patient will present with intermittent redness, pain, blood vision, and photophobia. The etiology is usually malposition, or like here it is a inversely placed ACIOL in the eye. Then it can be a decentered or subluxated IOL, where you can see the haptic in the in presence of PCR, a single piece IOL is placed and the inferior haptic can be seen in the sulcus. You can get a single piece IOL with a haptic in the sulcus. Sometimes it may not be possible to see the haptic position because of the poor dilatation. Then you can look for iris atrophic patches or pigment deposit on IOL. Definitely UBM will help you to diagnose the same. Sometimes IOL in the back can rarely associated with UGS, where they, especially when the patient has pseudophacoadenosis or plateau iris configuration, where there will be excessive fibrosis or a very large capsulorhexis, which is causing IOL tilt and causing optic, haptic, and uveal tissue contact. So presenting how you will diagnose, basically you will look for the iris translumination defect in the area of contact. You will get significantly pigmented trabecular meshwork on gonioscopy and UBM. So most important thing in these eyes is to see dilated evaluation of the lens status. You can do dilated gonioscopy also to see whether the haptic position is. As you can see in first diagram, there is a single piece IOL and haptic is placed in the antechamber. On gonioscopy, you also should look for the extent of cynical angle closure. UBM definitely helps to detect the exact position of haptic and any contact between the iris and uveal tissue and lens. In the first diagram, you can first photograph, you can see the IOL is nicely placed in back, while in second, the IOL is in sulcus. So here you can see the decentered IOL and subluxated IOL where there is a uveal tissue contact. Here the haptic is rubbing against the ciliary body as seen with the arrow. So differential diagnosis, you can confuse it with the acute anterior uveitis with raised IOP. However, pigmented KPs are more commonly seen in uveitis than UGS syndrome. So how you will treat this patient? Basically, you take care of intraocular pressure by using the aqueous suppressant, and definitive treatment would be IOL repositioning if the bag is cap integrity is good. However, if the bag integrity is compromised, you have to go for IOL removal and exchange it with either 3-piece IOL or SFIL. So risk factor are whatever is causing pseudophacodonesis, like past history of trauma, past vitreoretinal surgery, or presence of pseudoexfoliation. All these can be a risk factor for pseudophacodonesis, which in turn can lead to UGS. So how you will prevent? You have to ensure, this is the most important thing, that single piece acrylic IOL should not be placed in sulcus. It has to be placed in the bag. If you want to put a lens in the sulcus, it has to be either 3-piece or PMMA IOL. You have to remember that 3-piece IOL and ACL all are vaulted. So you should place it in correct orientation, not reverse orientation. For neovascular glaucoma, as we know, it's a secondary glaucoma, which is associated with neovascularization of the iris and angle, which is associated with raised intraocular pressure, and this damage may or may not be present. So a hospital-based study at the tertiary center has reported incidence of around 2.4%. This is most common etiologies are second retinal ischemia, which is usually seen secondary to central retinal vein occlusion, proliferative diabetic retinopathy, ocular ischemic syndrome, and other less common causes are like long-standing retinal detachment, chronic inflammation, or intraocular tumor. So pathophysiology is basically there is a retinal hypoxia, which lead to increased metabolic demand, which lead to increased VEGF expression, which causes formation of new blood vessel, which is also called angiogenesis. Why these new vessels are not good for the eye? Because they lack tunica media and they have a loose junction, endothelial junction, which make them leaky. And this leak material can, over a period of time, can form a fibrovascular membrane, which can form in the angle and block the trabecular meshwork, causing open angle glaucoma stage. And once it contracts, it causes synovial angle closure, causing the angle closure stage. So usually in the beginning, patient may not have any symptoms, but in the long term, they may present with significant vision drop with redness and pain. So stages of neovascular glaucoma are neovascularization of iris, open angle stage, angle closure stage. So neovascularization of the iris, you have to see iris under a very high magnification and concentrate at the mainly at the pupillary margin. However, you have to keep in mind that few percentage of patient can present with neovascularization of the angle first, followed by iris. So how we will differentiate these new vessel? Basically, new vessels are dichotomously branching. They cross the scleral spur and they are superficial, while the normal prominent iris vessels are ideal and they do not cross the scleral spur. So for the patient who has a florid neovascularization, as you can see in the first picture, the vessels are prominent, dilated, tortuous. And once you take care of the retinal ischemia adequately, these vessels can be seen constricted, which is seen in second photograph. So in open angle stage, you will get a neovascularization of iris, you will get a neovascularization in the angle along with the raised IOP. While in angle closure stage, along with neovascularization, you will have ectropy on EV and synovial angle closure based on gonioscopy. So sometimes patient will have an acute presentation, like they will have a symptomatic red eye with corneal edema. You might not able to see the neovascularization. However, you might get see some heme in the angle that should give you a clue. When you patient present like this, you should not confuse it with the acute angle closure glaucoma, where the other eye shallow anterior chamber will give you the clue. So for investigation, you should do a fluorescent angiography. Basically, angiography will give you the clue about the extent of ischemia. It can give you clue about the presence of early NVE or neovascularization elsewhere or neovascularization of the disc. OCT angiography is optional, advantage being it's a non-invasive but expensive technology. B-scan can be done, especially in presence of hazy media where you cannot see the fundus. It will help you to document the posterior segment pathology. In systemic illness, always remember to look for, see the blood pressure, blood sugar, HbA1c, do a carotid Doppler, especially if it is a ischemic etiology suspected, uveitis workup, if the vasculitis component is there, do a lipid profile. The most important, I would say, is the renal profile, because many times this patient will have compromised renal function, and without knowing that, we should not give them special injection mannitol. So how to manage this patient? You should reduce the posterior segment ischemia, control the IOP, and meantime, do not forget to control the systemic illness and control the inflammation. So how you will manage posterior segment ischemia? By doing the PRP, that is pan-retinal photocoagulation, and adjuvant intravitreal anti-VEGF injection. If you are not able to see posterior segment very hazy media, then you can go for anterior retinal cryopexy. If the patient has vitreous hemorrhage and is due for the retinal surgery, then you can do the endolaser at the time of surgery itself. You have to keep in mind that anti-VEGF therapy does not directly address the underlying ischemia as the PRP does. So the neovascularization regression can happen 4 to 6 weeks later post PRP, while anti-VEGF injection take few days. And you have to keep in mind that anti-VEGF injection lasts for few weeks. It's not a long-term solution. So medical management of the intraocular pressure consists of mainly aqueous suppression. You should avoid PG analog in cases of acute inflammation, and pilocarpine is absolutely contraindicated. Steroids and cycloplegics are usually useful in patient when there is a pain and inflammatory component. Surgical management should always be done after taking care of the retinal iris neovascularization and angle neovascularization by doing PRP and anti-VEGF. And once neovascularization regress, you can do trabeculectomy with mitomycin C, especially in a phakic eye. Glaucoma drainage device is a second option where you can do a wall implant or non-wall implant. Wall implant, the advantage is it gives an immediate IOP reduction. Glaucoma drainage device can be done in presence of active NVI also. So cyclophotocoagulation is usually reserved for the eyes with poor visual potential. And most importantly, you have to keep in mind that post-operatively you may face hyphema inflammation, which can reduce success of your surgery. So you have to take care of the retinal ischemia before surgery. So this is just a rough guideline about the managing the case. Like if it's a neovascularization stage, you just do the PRP anti-VEGF, and in other cases with glaucoma, you add IOP lowering medication. And if it is a very high, then you have to go for surgical intervention. So to conclude, neovascular glaucoma is a blinding disease which need early diagnosis and multidisciplinary approach. And you have to take care of the primary ischemia, intraocular pressure control. Thank you.
Wonderful, wonderful presentation, Dr. Trupti. It was very concise, at the same time very comprehensive. And these are two very, very important topics. I think the entire panel and the faculty agree that these two are the cases where you can easily salvage and easily mismanage both. So all the ophthalmologists and the students alike should know that these cases, especially neovascular glaucomas, can be saved with very good potential if you manage it the right way. Okay, so any other points that the elite panel wants to add? Manish, Manavdeep sir?
Yeah, I think very nice presentation, Dr. Trupti. One important point I think we should understand, especially those who are working in institutes, is that a lot of these neovascular glaucoma patients, especially patients with CRVO and proliferative diabetic retinopathy, are actually followed up with VR people, retina people, and not actually in glaucoma departments. And retina people generally see the patients post dilation. So a lot of time they miss these early NVIs and neovascularization. So one of the important thing is, in case you're working in an institute, you can train the optometrist also to do a proper sit-time evaluation. Sometimes they can diagnose these NVIs and can alert their VR people, because unless the VR people get informed, they will not refer it to a glaucoma person for a gonioscopy. So it's a teamwork. So sometimes training the optometrist also can be a useful thing. But all these patients with potential neovascular glaucoma like CRVO, proliferative diabetic retinopathy, we should have a routine sit-time evaluation and routine gonioscopies. The earlier we diagnose, they have a very good prognosis.
Okay. Anything else? Dr. Manju, you want to add something? We'll be seeing a lot of NVGs. We are a diabetic capital of the world, so lots of NVGs awaiting us. So we need to know the right management. Any points from you?
Yeah, Trupti, it was a very nice presentation, and I also agree with Manish that periodic examination is very important. Periodic anti-segment examination, including a gonioscopy, is very important in the practice of NVG treatment.
Yeah. And secondly, what Dr. Trupti has rightly pointed out again and again, I think a couple of times in the slide, is that PRP or laser is the definitive treatment and not anti-VEGF. So all those who are involved should know that the moment you inject an anti-VEGF, false sense of security creeps in, and then you forget to do a laser or the patient is lost to follow-up, then he'll lose the eye. So this is a very nasty glaucoma, comes back very hard at you, and comprehensive laser to ischemic areas is a must. Okay, and meticulous laser. You can't have sporadic spots. The lasers in these cases have to be very tight. Okay, so with that, I
there
think
is something which I like to say everywhere in every talk, including even the initial IOP talk, that you do not treat IOP, you do not treat neovascular glaucoma, you do not treat glaucoma, you treat human beings. So it is very important to take care of the diabetes that is related with this, which may not be very well managed. You need to take care of the kidneys, because many of these patients who are suffering from retinopathy, they are suffering from nephropathy and neuropathy as well. So we must treat the patient as a whole, and not only the eye, not only glaucoma, not only neovascularization, not only intraocular pressure.
Yeah, so that brings us to the point that the patient should be made aware of what has caused the disease, the etiology. They should be well informed about the risk factors and the management of the risk factors, and that the treatment of the eye problem is not the treatment of the primary causal agent. So that is very, very important. Point well taken, sir. So with that, I think we go to the next talk of the day. This is by Dr. Talveer from Punjab, and she'll be talking to us on principles of medical management, how to avoid mistakes.
Am I audible, sir?
Yes, you're audible and your screen is visible. So maximize the presentation, please.
Thank
Wonderful.
you.
Yeah.
Very good evening to everyone. So talking about medical management of glaucoma principles and avoiding mistakes. The goals of glaucoma therapy is first to halt the disease progression with least number and cost of medications for the patient. Also to maintain the quality of vision and the quality of life of the patient, and to educate and involve the patient into the glaucoma therapy care that we are giving to the patient. the most important step, I think everyone has been saying again and again, what to ask in the history and what to look on gonioscopy and how to examine the optic nerve. So the first thing is to establish the diagnosis. Most commonly missed things are usually like a small pseudo exfoliation that can be present in the eye, which could have been easily picked up on a careful slit lamp examination. Also, angle closure that is confused with open angle glaucoma. So it is important that all the steps in diagnosing the glaucoma are properly done. Once you have reached your diagnosis, you also assess the risk factors as talked by Dr. Gazella. Then after that, you set your target IOP, keeping in mind all the risk factors the patient has and the stage of disease that the patient is at. And after that, you initiate your treatment and follow up the patient to look for stability or progression of the disease. It's very important to not miss angle closure. In Western countries, angle closure is negligible, but in our country, not just angle closure. Angle closure is not a separate entity, but it is you can say it is a spectrum. So even people who are having open angle glaucoma may have a narrow recess in the angle, even though if they do not have goniosynechiae or they have very few goniosynechiae, combined mechanism glaucoma. So those are open angle glaucomas with a narrow recess that should be mentioned in the diagnosis of the patient. So once you come to target IOP, what do you look for in target IOP? What you want to see is what kind of optic nerve damage and visual field damage the patient has. Is it an early glaucoma or a moderate glaucoma? And according to that, you can keep a higher target IOP or a lower target IOP. If the patient is going to live very long, the patient is young, you need a lower target IOP. If the patient is very old in their late 80s and 90s, then we can keep a higher target IOP. If intraocular pressure at which the damage occurred to the optic disc was high. For example, in juvenile open angle glaucomas, if the intraocular pressure was 50, it was 40 when the damage was occurring to the optic nerve, then the target IOP can be slightly higher compared to a normal tension glaucoma, where the intraocular pressure, the damage to the optic nerve was occurring at even, just 20 millimeter of mercury. There you need to keep a very low target intraocular pressure. If the rate of progression is high despite being near to the target IOP, then you need to reduce it further much. Patient is one-eyed, you need to keep a lower target IOP. If the family history is present, especially if there is blindness in the family because of glaucoma, in blindness in the mother or father, then you need to keep a lower target IOP. Pseudo exfoliation and systemic diseases also, they contribute to lower target IOP. In advanced glaucoma intervention trial, it was shown that if the IOP was consistently kept less than 18, there was hardly any progression in the glaucoma. Therefore, once you know that this is your target IOP, the fluctuations in the intraocular pressure also have to be looked at, that the patient does not does not have those fluctuations. This brilliant article by Professor Sihota, what she has said is that we need to keep a clinically applicable target IOP range. So simplifying the target intraocular pressure to early, moderate, or severe glaucoma. So if we look at an early glaucoma, which has mean deviation less than -6, so more than -6, we can keep a intraocular pressure target of 15 to 17, in a moderate of 12 to 15, and in a severe glaucoma of 10 to 12. And furthermore, we can lower or increase the target IOP according to the individual patient himself. Also, a baseline diurnal is very important. So this light China trial, they showed that in the baseline, the intraocular pressure was higher in patients at 8 a.m. As compared to the entire day. So patients are usually coming in, not at early morning to us, so that we can see a higher intraocular pressure in these patients. Also, 50% of patients, they will have the highest baseline IOP at early morning. So at 7 a.m. or 8 a.m., if you can check the intraocular pressure, it will be the highest baseline pressure. So that pressure needs to be taken as baseline intraocular pressure for these patients. Now, we have various drugs that are already available in the market. The first line being prostaglandins, which lower the intraocular pressure for up to 30%. Then we have beta blockers and alpha agonists, which reduce the intraocular pressure to around 25% in practice. Rho kinase inhibitors also do the same. And in second line, we have dorzolamide, brinzolamide, which can reduce the intraocular pressure for up to 20-25%, and pilocarpine that can be added on. I'm not going into the details of the drugs because that's a separate topic altogether. So we know that the best drug is, the prostaglandins. So the first line drug that we choose is prostaglandins. When you start therapy for a patient, if a patient has early POAG or ocular hypertension, you can start with a beta blocker. Especially if you are giving medicine in one eye, then you should start with a beta blocker, because you do not want prostaglandin related side effects happening in one eye and the other eye looking totally different. And in moderate POAG, advanced POAG and NTG, you can use prostaglandins. In normal tension glaucoma, beta blockers are usually avoided. Why do we start with a monotherapy? Why don't we just straight away give the patient 2 or 3 drugs and just get the IOP to a lower part? Why? Because there are lots of non-responders that are present in the patient population. So in the OHTS study, 27% were non-responders to beta blockers. In CIGTS, 17% were non-responders, which means that the intraocular pressure did not reduce even by 15% after giving these medications. Also, to prostaglandins, up to 30% of patients can be non-responders. That is why you need to start with one drug. So these are protocols that have been given in primary open angle glaucoma guidelines by AIOS. So if you have an early glaucoma or a moderate glaucoma, you set your target intraocular pressure in early glaucoma of 16 to 18 and in moderate glaucoma of around 14 to 16, and you give one medication. If with one medication, you see that the intraocular pressure is reducing by more than 50 to 20%, then if the target IOP is reached, you can do a 6-monthly follow-up in an early glaucoma. If target IOP is reached in a moderate glaucoma, you can do a 4-monthly review. If the intraocular pressure is not reduced by 15 to 20%, you can think of one thing. First thing, that the patient is not compliant to medication, or the second thing, that the patient actually is a non-responder to medication. Then you can switch the medication and go and reach your target IOP. If the intraocular pressure is reduced by 15%, but it is not enough of reaching the target IOP, then you can add another medication, or you can add a SLT to the patient. In advanced glaucoma, similarly, you have to set the target IOP. If the target IOP is not reached with your medications, then you can think of compliance or switching medications or adding SLT, although it might have a poor response in these patients, and think of surgical modality if needed. But if the target IOP is reached, a three monthly review of intraocular pressure, structural tests like disc photo OCT and visual fields needs to be done. This is a protocol of looking after a normal tension glaucoma. In a normal tension glaucoma, it is written that you avoid the beta blockers because they can lead to actual progression of visual fields, and similarly, the treatment can be done. Now, in ocular hypertension, not all the patients need to be treated. If there is no risk factors like higher baseline IOP, older age or family history, thinner CCT, lower perfusion pressure, diabetes mellitus, myopia, disc hemorrhage, and the intraocular pressure is under 25 all the time, then what you can do is you can do an annual review. However, if it is a high-risk patient with intraocular pressure of more than 30 and there are multiple risk factors present, then what you can do is you can take a baseline reading of all the OCT and everything that you can get, and then you can start with one drug and you can reduce the intraocular pressure by 15 to 20%. If the 15 to 20% reduction is not happening or the patient progresses on this treatment, then you add on the treatment. So how to switch? We all know prostaglandins can be switched within the class. If alpha agonist, the patient has allergy, it is usually the drug allergy that is present, not the BAK allergy.
Half a minute to wind up.
Yes, sir.
Yeah.
So timolol, we all know that you can try a back-free formulation if there is allergy. And in carbonic anhydrase inhibitors, you can switch to brinzolamide. Combination therapy is usually better than multi-drug regimen because it improves the adherence and there is a lesser washout effect. So adherence is usually due to forgetfulness, unavailability of drugs. So when do you reset the target IOP? You reset the target IOP or additionally lower 15% of intraocular pressure if there is a new disc hemorrhage or a cardiovascular event or a stroke or a migraine, or there is still progression in the patient. Systemic drugs and diseases need to be looked after. And as sir has said, you always treat the patient and not the intraocular pressure. You discuss about the disease with the patient. You discuss that there is regular lifelong follow-up. You need to put only one drop of medication into your eye, how to instill the eye drops. Also, there is this disease process chart that is given by Dr. Spaeth, which tells us that we can tell the patient that you are in a green zone. So you do not need to worry. The anxiety that it's coming with your diagnosis, it needs to be kept aside. So all these things are very important while you're treating your patient. Thank you so
we
much.
need to wind up now, Dalvir.
Thank you.
Yeah. Okay, so that was a wonderful talk. I think it covered all the very, very important points in medical therapy, like target IOP, how to step up, how to manage the side effects, problems, and various permutations. So, any of our esteemed panel want to come in? Shweta?
I have one comment.
Yes,
Yes,
sir.
Yes, Sweta, you go ahead. Sweta, you go ahead. After that, I'll go.
Sir, Dr. Talvir, it was a very nice presentation because the management of glaucoma has got one role. That's the reduction of pressure with giving a good quality of life to the patient. And the good quality of the life can be attained only if we understand the last portion of your presentation, where you have said that if after a certain period you see that your pressure is not coming down beyond 15 to 20%, so instead of adding the drops, you can switch to the drops to the different groups. So that is how you can titrate and come to a conclusion that which drop is getting good for your patient and bringing the pressures down. So that way, definitely we can titrate and modulate the pressure for our glaucoma patients. So Manish, sir, I'm done, sir.
Yeah, Dalvi, nice presentation, Dr. Dalvi. One issue I have, you have mentioned ROCK inhibitor as a first line drug. I have slight reservations in that because a lot of side effects are there and IP lowering is not at par with prostaglandin. So I think I think the general trend is to use it more as a second and third line drug as not as the first line drug. Rest everything, a great presentation. Thank you.
I have a query here, which is mainly from Talvir and from the rest of the panel as well. How practical is it to have a target pressure of 12, lower than 12? How achievable is this pressure with the medical treatment, less than 12? I think it's very difficult for me.
So that's what I was about to tell now. There is a real target pressure and there's calculated target pressure. So looking at the progression of the disease, whether it's coming under control, we can have an IOP fixed, and that could be the target pressure. So initial treatment IOP, and look at all the stability of the disc and the fields, investigations and everything. And then we can set target IOP and see whether it's coming under control.
Okay, so excellent points. I think we need to move to the next topic. Just a concluding remark that medical therapy may seem to be simple, but you have to make sure that the patient puts the drop properly, as Talvir has said. The technique of installation should be seen. Patients may have handicaps, they may have only seeing eye, they may have a very tubular field. So whether they instill the drop properly or not, and above all, whether they close their eyes after putting the drop, because 90% of the patients who come to us, most of the time have not been told that they are supposed to shut their eyes. Certain cardiac comorbidity patients need to be told about punctal occlusion, and it has to be demonstrated to the patient and elicited from them. So these are small tips which can make a big difference.
So we have a video on YouTube how to apply eye drops that covers all these points, including the blind people. And it's just a 2 minutes video. You can tell your patient to look at this.
And one thing that I need to add is like chronic use of the drops. The patient, we have to also look at this ocular surface disease, the dryness of the eye with the preservatives. So we have to explain to them also where they might not be happy after everything under control. They may not be happy, it could be due to the drops.
Yep.
And Sachin, there are just 2 more points I want to add.
Yes, sir.
That which is very important, that people I have seen, they start with combination drug in the beginning. That point she definitely highlighted. But then if you give 2 drugs together, you don't know if both are acting or none of them are acting, or one is causing side effect, other is okay, tolerable. That is one. So never start that. If both the elements are necessary, then later on you switch on to the combination. And the second thing, that always the pressure is something which tells you in follow-up the efficacy of your intervention, whether medicine or laser or whatever. But whether it is sufficient or not, that will tell you, that you will judge by perimetry or OCT follow-up, so that whether it's stable or not. So even if target pressure is whatever you have decided, not reached, but if it's not progress, then probably then there is no point adding some more medicine or switching to any other.
So proof is in the pudding. Point well taken. Okay, so with that we go to the last talk of the of these of the day, apart from the Saransh. So it is on surgical management of glaucoma, when and which my rationale by Amit Pandey. He practices in Gujarat.
Thank you, AIOS and GSF for this opportunity. I'll be giving my rationale on surgical management of glaucoma. I don't have any conflict of interest. I'll be talking about this topic on these subtopics. Why, what is the benefit of doing a surgery? When do we do a surgery? That is the indications of surgery, and how with surgery and how to do it. I have excluded lasers from this talk. Why we know glaucoma is one of the biggest causes of blindness worldwide, and blindness is pretty common with glaucoma. We have 4.5 million people who are visually impaired, and out of them, 1.5 million are in India. It's only going to increase in the next decade and two. So what are the benefits of surgery? We get a more stable IOP without medications. We get lesser visual field loss. We have less adherence and compliance issues, which probably is the biggest problem with medical management right now. We have lesser red eye and ocular surface disorders, and overall a better quality of life. The surgeries that I do are MIGS, of course, bang in that, which is the most affordable of all MIGS. KDB glide, excision goniotomy, and eye stent. Trabeculectomy, of course, is the gold standard, and I also do the glaucoma drainage devices, that is the AGV as well as ACP. Indications for surgery, glaucoma refractory to medical management, your target IOP has not been met and patient is showing progression in spite of maximally tolerated medical management. Glaucoma patients with significant cataract, if turn up for a cataract surgery, I would think about surgery there. And moderate, severe, and advanced glaucomas, which are non-compliant patients with allergic to medications, contraindications to medications, and who are unable to instill eye drops, I'll be thinking about surgery. A common scenario that we encounter is a primary glaucoma who comes up with a cataract. So the question there comes whether to do a phaco alone or do a combined procedure. So these are the factors that I look into while deciding. The life expectancy, if it is high, I would think about doing a combined procedure. If the glaucoma is more advanced stage, I would think about surgery. When the target IOP is not achieved and progression is happening, and patients who are on multiple medications, 4, 5, 6 medications per day, and has got a significant cataract, I would think about doing a combined procedure there. So the question again comes whether you do a MIGS for that or a TRAB for that. The most important factor deciding this would be the stage of the glaucoma. So if it's a mild or moderate glaucoma, I would think about doing a MIGS. And if it's a more severe and advanced glaucoma, I would be thinking about doing a TRAB. The angle status also is important to the extent of pass. If there is extensive peripheral anterior synechiae, I would not do a MIGS in that case. Duration and life expectancy is also something that we consider. So basically, MIGS, the best patients to do MIGS are mild to moderate glaucomas who are undergoing cataract surgery, open angle glaucomas on multiple medications, and the points that we discussed. And why mild to moderate glaucomas? Because in advanced and long-standing glaucomas, the collector channels in the Schlemm's canal might have already collapsed, and hence the angle surgery might not be very helpful there. Avoid in these patients advanced glaucomas, secondary glaucomas, of course, are a big no-no. And one special indication that I've been doing now is post-filtration surgery when the IOP requirement is not very exorbitant, IOP reduction requirement. I've done, I think, 9 MIGS now after post-TRAB cases. So which surgeries? Bent abintern needle goniectomy is the most cost-effective one, where you take a 26-gauge needle, bend it at the tip around 60 degrees, and with the direct gonio lens, you excise the trabecular meshwork of the nasal and the inferior nasal angle. This lens that I'm using is the iPrism SX. Again, no conflict of interest there. You excise how much you can see. That area you can excise. You'll see blood regurgitation, which is a good sign. These are the collector channels which are regurgitating blood. So it's a good sign that you have completed the procedure. A better way to do that is the KDB Glide, which is a much better instrument as compared to a 26-stage needle. The gonio lens that I'm using here is the Oculus Gonio Ready, which is again no conflict of interest. With the direct gonioscopic view of the angle and holding the globe, because this is a hands-free gonio lens, you go in and start in the middle. This is the inside-out technique, which I usually do. You start in the middle, go to one extreme, turn around, and go to the other extreme. It cuts much smoother and without much collateral damage, and hence is a better procedure than bang. The eye stent, this is the India's first eye stent inject W that we did a few months back. You go in absolutely perpendicular to the trabecular meshwork. You visualize the trocar in the middle window, cause a small dimple in the trabecular meshwork, and press the blood button to inject it. And around 2 o'clock hours to the other side, you repeat the same steps. Go in perpendicular, visualize the trocar. You can see it here if it is visible, and you'll see the implant going in. Blood regurgitation again is a good sign. TRAB, of course, is the gold standard and the mainstay of surgical management in glaucoma. I do it with the mitomycin C in most of my cases. I use around 0.4 mg per ml for a minute. And of course, we need to wash it off with copious amounts of saline. I make a triangular 4x4 mm scleral flap, and I use the Kelly sponge to create the ostium. And this is the PI done. I take a apical suture as an interrupted suture. The right side suture I take as a releasable one. People have different techniques. I put 2 interrupted and 1 releasable. And then close the conjunctiva in a watertight fashion always. So what happens when a bleb fails? If the target IOP is achieved, we do regular checkups, even if the bleb is not very high and very good looking. But if the target IOP is not achieved, we try to salvage the trab. If the ostium is patent, then we do bleb needling. If that is successful, we observe. And if it fails, then or if the ostium is already closed, we see if useful vision is there or not. If it is there, we start off with medications. MIGS is controversial, but it's working in a few patients that I've done. Retrabs is an option. I don't usually do retrabs. I directly jump onto the glaucoma drainage implants. If there is no useful vision, we plan a cyclodestructive procedure. So drainage implants, one or more filtering procedures that have failed becomes an indication. Refractory glaucomas like neovascular glaucoma, traumatic glaucomas, uvitic glaucomas is something that, or with extensive scarring in the superior conjunctiva is where I would think about doing a tube. Post-VIA surgery, syndromic eyes like aniridia, Serge-Weber eye syndrome are other indications of doing a tube procedure. This is the ACP or the clear path. The advantage of this is it goes through a very tiny conjunctival opening, conjunctival peridermy of around only 4 to 5 mm. So we dissect the subtenon's dissection is done. Mild cautery. And this is the Grover fenestrator device where you can put in the implant, and it has these grooves through which you can pass a 26-stage needle to cause the fenestrations in the non-valved implant. That gives consistent results. And of course, we ligate the tube because it's a non-valved implant. We fold it and put it through the conjunctival opening. So that's how it goes in through a very small opening. And these anteriorly placed suture holes also aid in the of the device, makes it much more easier. A pre-placed Prolene suture is already there in the tube. So we make a 23 gauge tunnel and put in the tube, secure the tube to the sclera. I use a scleral patch graft and glue over it and put 3 or 4 conjunctival sutures to close the. That's it from my side. Thank you so much.
So wonderful presentation, excellent videos, Amit. Really good. I think Siddharth has also joined us. Siddharth, any tips about what is your rationale? What is your choice?
You're
muted. You're muted. You're on mute.
Thank you, first of all, for having me here, and apologies for joining late. And I agree with most of the things that we just heard from Amit. And one of the indications that really MIGS has become kind of a savior is when you are in a patient who has advanced glaucoma or a failed TRAB, and you foresee a lot of risk in doing a TRAB or an implant. So that I think is an emerging option, and we have a publication coming up on the same topic. And in fact, it was published the last month, and that shows that there is a scope for MIGS even in some certain situations when you use it very safely. And when you're looking at reduction of medication, or you just on the verge of control, it's not like for a very advanced glaucoma where you're trying to replace 4 or 5 medications. So I think that was the highlight. And of course, the quality of the surgical videos and surgeries has always been excellent from Amit.
Thank you.
Good. So any other comments from the panel about their rationale, what they would do different?
Yes, Sachin,
Manish,
actually,
Amit?
I do agree with what Siddharth was saying. My indication for MIGS also has increased. Earlier, it was only mild to moderate glaucoma. But now, even in case of failed TRABs, I go ahead with MIGS surgery to reduce the pressure. So the indications of MIGS are changing from mild to moderate glaucoma to now even angle closure cases, even with failed blebs, even in angle closure cases after doing a GSL, I do a MIGS procedure. So the indications are going on changing, and we have to be updated with this.
So which MIGS do you practice?
I do a bang KDB and microgoniotomy.
Sorry, bang and?
Bang KDB and microgoniotomy.
Good. Any other additions, Manju?
Before calling a TRAB as a failed TRAB, I think it will be better if we do a gonioscopy to see how the posterior is and the punctum is, and then we can decide on what surgery we can do next. So that could be one take-home message that you can tell the people.
Definitely.
Even a needling should be tried if you tell it as a failed TRAB before going for a surgery. I mean, I have done cases where the failed TRAB of quite a few years, the TRABs were failed and totally flat bleb. Needling along with the goniotomy, that also helps us in reducing the pressure.
Exactly. That's what I wanted to tell.
Yeah. So absolutely, every bleb has to be, you have to try to salvage every bleb, because whatever said and done, the best pressure control is in a successful trabeculectomy. So that we all agree. Consistently low, and we can get in low 10s and even slightly less than 10 on some occasions if we are lucky. So with that, I think we move to the last topic of the day, and that is the Saransh. And to present it, we have my good friend Siddharth Dikshit from LV Prasad, and he will be giving us a gist of journal articles from glaucoma in the last 1 year. Over to Siddharth. Thank you.
Right. Thank you for giving me this topic. I felt I will really enjoy it. When we spoke, we talked about the most important articles from the last 5 years. But then I thought that, look, 15 minutes is not a time good enough to teach people or give the entire message that an article has, that to 5 articles. So I thought I will focus on, I took this liberty without discussing on 5 articles which have really created an impact on me in different senses at different times, and change sometimes the course of glaucoma or glaucoma management, not only for me, but for many people. So this is not a journal club. I will try not to do it journal club style, and hope you have a good time while you listen to this. And I will start from the roots or the origins. And this is also an homage to who I consider he headed my alma mater for a long time. I have not been in personal touch with him, but when I read his paper and I attended a CME, I was sold to glaucoma right in the first year of my diploma in ophthalmology. And the reason I have spoken first about this paper is every time I went to it, I found something new in this paper. And in this paper, perhaps, is a very good summary of what the book on automated static perimetry by Anderson and Patela is. So every image in this article is iconic. And I think this is where, for the first time, the visual fields were divided into 8 zones. And then it became the norm, and it has stayed the norm for many decades after publication also, that the fields are always divided into 8 zones whenever you're talking about a visual field. So this is the impact, and this was taking me one step closer to understanding glaucoma. Now, once in a while, there comes a paper which can be a path breaker or dares to talk about something which not has been spoken of always. And though this is almost 3 decades back, Oates was that paper which did it for me in terms of ability to understand research in glaucoma. Do you believe that right from the time when this study started, they had a website dedicated to the study, and where you could download all the articles and the manual of procedures? So for anyone who wanted to study how a randomized controlled trial should be performed, they just had to download this manual, which gave you every detail. What is the entry criteria? What is the exclusion criteria? What will be the tests which will be performed on these patients, and every possible thing. Apart from that, the study had a beautiful design. So they had followed up from the last publication for the entire group, patients for 13 years. And for the first 5.5 years, they had a treatment group and a control group. And at the end of 5.5 years, apart from a small number of participants, rest of them were started in treatment. And these patients were from the delayed treatment group. So this is such a long followed up study where the loss to follow up was minimal. And what did we learn from this study? I think this is what can possibly summarize the study completely, this table. If you go by just the intraocular pressure, you may not be able to treat these justifiably. But if you look at primarily the central corneal thickness, the age of the patient, and then assess whether they are low risk, middle risk, or high risk, you will be justified in not treating the lowest risk people, where there is no difference at all between the medication group and observation group. If you go to the intermediate risk group, you find that there is a difference in the mean, 14% versus 19%, but the confidence intervals are overlapping. So here also the risk is not much. But the moment you see a thin cornea, the moment you see a young individual, you are bound to treat it. So this was a wonderfully conducted study. Even the way patients were recruited as volunteers and the endpoint and progression was defined was amazing. And the manual of procedure and the study itself is a lesson for anyone to understand what randomized controlled trials are. Now, from a wonderfully conducted study to what I can say, a very popularized, very fashionable study, the tube versus trabeculectomy study. The authors celebrated the publication of this study very significantly and very prominently. But what was the problem with this paper? Now, this paper concluded that the probability of failure in the tube group was 29% versus 47% in trabeculectomy group. And so was the difference in the reoperation rate for glaucoma. I will go into a little bit of details for this study. So clearly they are saying that tubes are better. Now let us look at what happened. They randomized around 100 patients in each group and followed 70 to 75% of those patients for 5 years. Wonderful study. 5 years and follow-up of 100 patients. It's not easy. Excellent. The baseline study characteristics were similar. Now, what were the results? When you look at the results, they found that the intraocular pressure control was similar in both the groups at almost all the endpoints. And the difference is not significant statistically. Apart from a few exceptions, in most of the strata or subgroups, the tubes actually did better. And one place where you thought it may do better, the previous cataract extraction, even there, the difference was in favor of the tubes. And there was a huge difference in reoperation rate, whereas tube versus trabeculectomy is concerned. And that proved, according to the authors, that trabeculectomy tubes were better. Now, let us go a little more deep and open your third eye. Now, you look at this carefully, and at the end of 5 years, in a world where difference of 1 millimeter of mercury is celebrated with pomp and show, the mean is different or lower in the trabeculectomy group by 2 millimeters of mercury. Its difference may not show up in the numbers, but clearly the trabeculectomy group has lower mean. Look at the percentage of reduction of different groups and compare it to different trials. So the 5FU doesn't reduce intraocular pressure much. The TVT study tube group had 42.6% reduction, which was lower in patients who were treated with either 5FU in the Singapore study, the CGITS, the TVT trap group, and the ABC study. So it was worse than all other studies, but still the authors claimed that it was superior to trabeculectomy. Was trap better at preserving visual fields? Yes. If you look at these numbers, it is not statistically significant, but yes, the slope or the worsening is better in trabeculectomy group than in tube group across the 5-year period. And why is then the reoperation rate higher in the trabeculectomy group? There is nothing but reoperation bias or counting the number of surgeries, interventions more strictly in the tube group. And they followed it up with the PTVT study, which really didn't show any difference between the groups. And world over, nobody has adopted the practice of doing implants over trabeculectomies when both can be done. Yeah, probably there is a small number, but not much. And again, look at the qualified success of the trabeculectomies in different studies. Okay, these are the tubes. They did really well when they compared themselves to the other tubes. But when you look at the success of trabs, the TVT trap group was worse than the other randomized control trials, which basically means trabs, when done well, they will do better than the TVT tube group. So I'll just end here pointing out again that the complications of trabs was also much higher in the TVT group than the other groups. And in my opinion, this is what the study was. I will, looking at the time, probably just end with this study, which was an eye-opener for me and changed my practice forever.
We have 5 minutes, Siddharth. We have 5 minutes. Relax.
We have 5 minutes? Okay.
Yes,
yes. Okay, so this is a study that came from Singapore and was a very well conducted study on acute primary angle closure. To be able to do a randomized controlled trial on acute and primary angle closure is not easy, but they did it. And they randomized patients who had achieved pressures of lower than 30 within a day of presenting to laser PIs and direct phacoemulsification. And they showed that the number of eyes which did better on phacoemulsification was significantly higher, and the number of times they needed resurgery or medications was significantly better with direct phacoemulsification. The visual acuity was similar, but if you look at the amount of PAS that the patients developed at the end, that was also similar. What was okay, so the survival and the intraocular pressure was much higher in the patients with phacoemulsification group, and it did much better than the direct laser PI. And that changed my practice. And this is a set of patients where who presented with acute angle closure. And if you see, these patients received surgery within clear lens or a very early cataract and cataract extraction because the IOP was not controlled with medications within the first month. And you see, in each of these cases, the number of medications has reduced. Now, let us look on why we don't directly do phacoemulsification for patients who have acute primary angle closure. Because even when you do a cataract surgery in these patients late, like these patients, significantly much later than the first month of presentation, you can still reduce the number of medications that you're using to significant extent. And in fact, better than what you would do if you do it early. So we are still kind of working on the long-term outcomes, and that probably should show a greater or great results in greater light, and that is what probably we should look at. But in the short term, with this kind of follow-up, cataract surgery can wait, do a PI. If not, doesn't get controlled, then you can do a phacoemulsification. If not, then we can go ahead and wait. Now, this study has a twin: phacoemulsification in acute angle closure versus phacoemulsification in very early angle closure, and that is the EAGLE study. Very significantly discussed. And while this study or this publication focused on the quality of life and the financial impact, there are certain things that we should all look at beyond this. So this was a very large-scale randomized controlled trial. And if you look at the outcomes of this study in different aspects, there are certain things that I want you to follow. Look at the clear extraction versus laser PI group. The intraocular pressure is lower, 16.6 versus 17.9. The number of medications that these patients ended up at 36 months is significantly lower in the eyes which had a clear lens extraction. The number of patients who needed additional glaucoma surgery, very significantly lower. The number of patients who had acute angle, this is something else, sorry. The number of patients or the extent of synechial closure at the end of 36 months is significantly lower again in the clear lens extraction group. But why should we not always take out the lens in these patients? Because there is a very real risk of having a significant complication in an eye, which, if you are talking about clear lens extraction, doesn't even have a cataract. Because of the risk of these significant complications, Even if I develop glaucoma, angle closure glaucoma, or someone in my family develops angle closure glaucoma, we cannot subject them to clear lens extraction, but have an eye open. And whenever you get an opportunity with an early cataract also, you can benefit them by performing an early cataract surgery the moment they get symptomatic. And you just keep this information shared with your patients with angle closure disease. So there is something to take. Maybe we should not be doing clear lens extraction, but significant take-homes in terms of advantages that you can provide to patients with angle closure disease. And a lot of angle closures are like this, where the lens is a very significant factor. Image them, do a biometry, look at the lens vault, look at the lens thickness, and then probably take this decision on whether you want to take out the lens or not. I will close here with this image, and I think because Dr. Sachin had seen Anupam Kher in Saransh, she remembered me when he thought of this topic. Thank you.
Okay, wonderful. So, very enlightening lecture, Dr. Siddharth. Often less talked about things, less systematically normally. You made light of a very, very difficult topic. So, anyone in the elite panel wants to comment anything on this, on how to, on the studies that he has quoted and their personal opinions or practice patterns?
I think he has, really picked up very good studies, and all of these studies had an impact on my personal practice as well, and little less in favor of clear lens extraction, but most of the other things, yes, they have impacted the same way as they have impacted Dr. Siddharth.
Yes, Naik sir, any comments on these studies quoted?
Yes, definitely he picked up, means all whatever study he presented just now. It's really they are now I realize that they are so important. Probably I had not given so much importance to them earlier, except the first one which he showed about the perimetry thing of Ravi Thomas article. But then all others also he made it look so important, and it is really so. So it's a congratulations, Siddharth, for presenting it in such a way and convincing manner. That is the important. And about the clear lens extraction, I had similar opinion that in case, because as he said at the end, that it's not that I will immediately jump for clear lens extraction after this, but in case if there is a first opportunity for doing it, or if the morphology is something which is suggesting that you should do it, then you should do it. And this is what I follow for that.
Any remarks from anybody else?
Sachin, I would like to pass a comment. Siddharth, it's not an easy task to present Saransh, what topic Sachin has given. I mean, it is very, you have to read the articles judiciously, take out the silent features, speak it out. It's not an easy job. And I think this is an ARC webinar also where a lot of PGs are watching. So practice of evidence-based medicine is very, very important. And all those PGs should go through the important landmark trials of glaucoma which are conducted, so that it helps them in their practice. And we should practice what is called as evidence-based medicine, which we always stress upon in all our GSI conferences. So this is a very nice. I had written an article on landmark trials in glaucoma in one of the textbook, and trust me, it is not an easy job. So congratulations, Siddharth, for the wonderful presentation.
Yeah, so the summary of it is, it was not an Anupam Kher moment. It was a right selection.
Yeah.
Okay. So any concluding remarks from any of the expert faculty before Dr. Anga takes over? So we had a wonderful evening, the last 2 hours, summarizing all the salient points that everybody needs to know. The students from the theoretical point of view, ophthalmologists from the practice point of view. All the presentations were very, very practical. I thank all the presenters, the AIOC, the AIOS, ARC, represented here by Dr. Anga, and Dr. Prashant for having this this wonderful event, and I think it will benefit many people. Over to you, Dr. Anga.
Yeah, thank you so much, Dr. Sachin and Dr. Siddharth, absolutely amazing presentation. And I think this webinar is going to be an iconic one. And I think it's going to be a practical textbook for all, not only postgraduates, but also practicing ophthalmologists. So I wish to thank each one of you, the expert panel, for being here, sparing your valuable time. Dr. Sachin, Dr. Amit, for being amazing moderators, for all the speakers who have given so much time and attention to every detail so that each topic has been dealt with threadbare completely. And Dr. Siddharth, of course, for the complete gist of all the articles. Thank you to our AIS President and ARC Chairman, Dr. Prashant, who have always been very, very cooperative and have come up with such good topics so that each topic is covered in detail. So thank you one and all once again from the bottom of my heart for making this wonderful webinar so amazing. Thank you.
Yeah.
Thank you.
So indeed, the AIOS committee as well as the president and secretary need to be congratulated. Fantastic concept actually, and including Saransh at the end is a really icing on the cake. So entire team should be congratulated.
GSI also.
Thank you.
And the GSI, obviously.
Yeah. Dr. Nayak sir
and GSI, thank you.
Full support of GSI to ARC.
Thank you. Thank you so much.
Thank you for the opportunity.